Hello, guys. I hope that you all are doing fine. And we need to start today with the topic named candidiasis. It is very important topic, and you will get one scenario on this topic for sure, like one or two. Okay, so read it thoroughly and yeah. Okay, so Candida species are a commensal organism of the oral cavity, and oral candidiasis is an opportunistic infection. So, opportunistic infection, you know, right? So, these are the type of infection they happen when your body's immunity gets lower down. Okay, so whenever there is opportunity, so it's like opportunistic infection, and it is very uncommon to see in healthy individual. Okay, and however, it occurs relatively common in neonates. Then here, this table, it is a very important table where they have listed the causes, why, what could be the risk factor in your patient that might leading him to the candidiasis, and gives an overview of the clinical features, predisposing factor. We will read in detail what are the clinical feature, predisposing factor, and how we will manage different types of candidiasis. Okay, and if any red flag feature of oral mucosal disease are present, then you need to refer to specialist. So whenever like any disease or any lesion patient have, wherever you see any red flag feature, you just need to refer the patient to the specialist. All right, so these are the common risk factors for oral candidiasis. Local factors include if your patient is wearing denture. Okay. Secondly, if there is salivary gland hyperfunction, it means if your patient complains about dry mouth. Then corticosteroid inhaler. So corticosteroid inhaler, it decreases our immunity. Okay, and secondly, it can also leads to dry mouth and poor oral hygiene and smoking. Okay, so these are some of the local risk factor that might be the main cause of oral candidiasis, and systemic factors could be immune compromise and drugs. So you can just correlate these things, like the drugs would cause dry mouth, right? And the immunocompromise and the corticosteroid inhaler, they both would lower down the immunity. That would expose your body or expose your patient's body to get more opportunistic infections. Okay, which is the example of immune compromise is the poorly controlled diabetes. And drugs, mainly systemic corticosteroid and antibiotics. So if the patient is taking antibiotic from longer term, there is a chance of getting candidiasis. Then, for management of oral candidiasis in patients receiving palliative care, it means like the patient who are in hospital, you do not need to worry about them. They would be managed in the hospital only. Okay, and if the management of oral candidiasis in immunocompromised patients requires specialist advice. So, for example, in HIV positive patient like here, so you know the candidiasis is the characteristic sign, right? So it is a one of the first sign that does appear in the HIV positive individual. So even that is the case, or even patient is immunocompromised, you are not dealing with him. You are just referring him to the specialist. Okay, then certain types of the candidiasis. First one is the pseudomembrane candidiasis. So its name state that it is a pseudomembrane. Okay, so clinical feature would be it would be creamy white curd, papules and plaques that are sometimes removable. So there is a pseudomembrane, you can remove it. Okay, and the how would be the appearance? It would be creamy white curd, and there would be the base would be red, raw and often bleeding base, and on top of that these creamy white curds. So this is pseudomembrane candidiasis, and it can also sometimes be removable. It is generally asymptomatic, and it can affect oropharynx. If the dorsal tongue is affected, autoinoculation of the palate may occur. And what would be the predisposing factors? These are local factor and systemic factors. Okay, and it can also happen in neonates. Management would include for the management, the first point is to find the cause of the problem. Which is the cause? You need to discuss these things with your patient, like what is causing candidiasis in his body. Okay. Then use topical antifungal therapy for oral candidiasis, and if the infection affects the oropharynx, then you need to refer to the specialist. Then erythematosus candidiasis, as the name states, it would be red in color. Okay, so it is sensitive red lesion. So here it is asymptomatic. Here it is sensitive red lesion, and it commonly happens on the palate and on the tongue. Okay, the tongue may appear depapillated and smooth. Predisposing factors would be same, and it could also be caused by broad spectrum antibiotic therapy. Here, the predisposing factor was neonates, which is the pseudomembrane, and erythematosus, broad spectrum antibiotic therapy. And what would be the management? It would be same, like addressing predisposing factor and use topical antifungal therapy for oral candidiasis. Then the third type, which is the hyperplastic candidiasis, it is asymptomatic, and it is non-removable white plaques that may appear nodular. So this appearance is just like a nodule, and it is white in color. It is plaque in shape, and it is non-removable. This one, pseudomembrane, was removable. Okay, and it usually affects the retrocomistral or anterior buccal mucosa and lateral tongue. So its site is retrocomistral or anterior buccal or the lateral tongue or buccal mucosa. Okay, and it may be bilateral as well, and it resembles oral leukoplakia, as we read in oral leukoplakia case that they have given the differential diagnosis, they have given chronic candidiasis. So this was the type of candidiasis which does may resemble leukoplakia and or oral cancer. Predisposing factors would be the same risk factors. Management would address the factors and may be associated with epithelial dysplasia. So, for this type of hyperplastic candidiasis, you need to refer to a specialist to do the biopsy and for the management. Okay, and the angular cheilitis. There would be, I believe, there would be one scenario on angular cheilitis and one on denture stomatitis for sure, because these are very common problems that we does see in our patients in regular basis. Okay, so angular cheilitis clinical features would be painful erythema and fissuring of the corners of the mouth, and it is usually caused by a mixed infection of Candida, Staphylococcus aureus, and Streptococcus species, often associated with intraoral candidiasis. Okay, so outside there would be this lesion, and inside the patient is often having intraoral candidiasis. The predisposing factors would be same as we read in that box. Plus, on top of that, there could be any deep skin folds around the mouth that might be leading. Deep skin folds can be caused by worn down teeth or ill fitting dentures or not wearing the dentures. Okay, so that's the area where more saliva would seep in and it would attract more bacteria and fungus to cause the infection. And sometimes even the deficiencies, mainly iron, folate, or vitamin B12 deficiencies, Crohn's disease, granulomatous disease, atopic and seborrheic dermatitis. So these are some of the predisposing factors for angular cheilitis. Management would include dental review to assess dental or denture related causes. You need to find out what's the cause in the patient. Like, is it the teeth related cause or is it the denture related cause that the patient's denture is very old and it is worn out? So this is the time to change the denture or get him treated. And the second step would be to address the predisposing factors which might be leading. So you need to find out which factor. Then use topical antifungal therapy for angular cheilitis. So for angular cheilitis, the antifungal therapy is bit different than the oral candidiasis we will read in following pages. Treat oral candidiasis if present with topical antifungal therapy for oral candidiasis, because here we have seen that it is often associated with intraoral candidiasis. If patient is having both of these lesions, then you need to prescribe antifungal therapy for angular cheilitis and antifungal therapy for oral candidiasis. So they could be so we will read here, like for the angular cheilitis it's these ones, and for the candidiasis it's these ones. Okay, then denture associated erythematous stomatitis, which is the denture stomatitis. So this is a type of infection or irritation caused by the denture wear. Okay, this is sensitive erythematous lesion confined to the denture bearing area. That's the reason it is called denture associated, and particularly the palate where the denture would sit. And it may appear punctured or smooth and red. Nodular hyperplasia may be observed. What would be the predisposing factor for this one? Like if the patient has ill-fitting denture, his denture is not fitting properly and it is causing trauma to the area. Secondly, it could be suboptimal oral and dental hygiene, which means that the patient is not taking the denture out during the night time and not keeping it not cleaning it with the soft brush and mild soap and keeping it dry overnight. So if the patient is not following this denture hygiene, then it might lead to denture stomatitis. And there could be some dietary factors, which are the deficiencies could also be one of the cause of causing this thing. Then management advise patient to optimize denture hygiene and to remove dentures at night. So for this management, you need to advise them that it is very important to perform the denture hygiene, which means that remove the dentures at night, clean them, and then store them dry overnight. Although previously it was mentioned that store the dentures in the water, but now they have changed. Like if you will store the denture in the water, then it would increase the chances of getting it, the causing it infection. So they have said that dry medium would be better than the wet medium. Then dental review to assess fit of denture. You can also make a review appointment for the patient to assess the fit, if it is fitting him properly or not. Either it is causing the trauma to the tissues or what's the fit. Then if symptoms do not resolve after 1 month, so you only need to do these two steps until 1 month and wait and see that patients and this thing would go away, like it would be treated by its own. Like, but if there is a scenario that even after 1 month the patient and of optimal oral and denture hygiene, patient is following your routine of cleaning the denture and taking it out, use topical antifungal therapy for oral candidiasis applied inside the mouth and to the dentures. Okay, so you need to start the antifungal therapy after 1 month, and that therapy should be such that you need to apply it over the palate and over the inside surface of the denture. Okay. In other, we are just prescribing antifungal straight away, but for the denture stomatitis, you first need, it is very important that you advise your patients about the denture hygiene and wait for 1 month, and afterwards you advise them or prescribe them the antifungals. Then median rhomboid glossitis, rhomboid area of depapillation and erythema in the midline of the dorsal tongue. It may be fissured or nodular. Autoinoculation of the palate. Like, can you see this is the autoinoculation? So here the lesion is on the tongue and this thing has autoinoculated on the palate. Okay, autoinoculation of the palate may occur. Usually it is asymptomatic, although it may sting or burn. Predisposing factors would be the same, that box, and the management would be address predisposing factors and use topical antifungal therapy for oral candidiasis. Then antifungal therapy for oral candidiasis and antifungal therapy for angular cheilitis. So what's the difference? For management of oral candidiasis in patients with HIV, you just need to refer to the ETG. Even if the patients are in palliative care, ETG. Patient is immunocompromised, specialist. Antifungal therapy is not always necessary for oral candidiasis and candida associated lesions. For indication for antifungal therapy, successful treatment relies on adequate contact time between the antifungal and the affected mucosa. So advise the patient not to eat or drink directly after administration. So it's it is very common thing, right? So we just need to advise our patient to leave it as long as they can, these gels, so because we need the adequate contact time to work, that these antifungals would work more efficiently on those lesions. Then treat oral candidiasis in neonates and children younger than 2 years with a topical antifungal. In infant, apply the dose in the front of the mouth to avoid choking. So here they have divided the doses in according to their age. If the kid is younger than 2 years, then you can give him nystatin 100,000 units per ml suspension 1 ml topically 4 times daily after feeding for 7 to 14 days. Continue treatment for 2 to 3 days after symptoms resolve. For micon, or you can give them miconazole 2% gel 1.25 ml topically 4 times daily after feeding for 7 to 14 days and continue treatment for at least 7 days after symptoms resolve. Then treat oral candidiasis in adults and children 2 years and older with. If the adult and children is 2 years or older than that, then you can give them miconazole 2% gel 2.5 ml topically solution, then swallowed. They do not need to spit it out, they can swallow it, and 4 times daily after food for 7 to 14 days. Continue treatment for at least 7 days after the symptoms resolve. So just, logically you won't be getting any patient younger than 2 years in exam. So just, if you want to remember the doses, just try to remember these doses, which would be beneficial for you and easier for you. Okay, and or which other prescription you can prescribe them is the amphotericin B 10 milligram lozenges. So they are a type of lozenges. It is a gel or and it is a suspension. Okay, so they can suck it and then swallow 4 times daily after food for 7 to 14 days. Continue treatment for at least 2 to 3 days after symptoms resolve. Or you can give them nystatin 100,000 units per ml suspension 1 ml topically 4 times daily after food for 7 to 14 days and continue. So for the continuation for amphotericin and for nystatin it's same, like 2 to 3 days. For miconazole it's 7 days. Then advise patients with the denture to use miconazole or nystatin because the antifungal should be applied to the fitting surfaces of the denture at least twice a day. Okay, so these are lozenges. So if the patient has denture stomatitis, so these would not be of much help. So what denture stomatitis patient can use either the gel or the suspension form and advise them to apply it 2 times a day. Dentures should be removed from the mouth at night, then cleaned and stored in a dry environment overnight. And we will read for the denture cleaning instructions in detail in page number 275. Evaluate patients with intractable candidiasis for systemic disease, example, if any diabetes or HIV infections. And then antifungal therapy for angular cheilitis. This is a bit different. So it is either clotrimazole 1% cream topically to the angles of the mouth 2 times daily for at least 14 days and continue treatment for 14 days after the symptoms resolve. Or you can prescribe them miconazole 2% cream topically to the angles of the mouth twice daily, 14 days, and then continue for 14 days. Okay, so this miconazole and this miconazole is bit different, as this is a gel and this is cream, and this is 2.5 ml topically, and here they have not given any percentage amount. And here you for anti-angular cheilitis you need to continue at least for 14 days, and for the other candidiasis the patient needs to continue the treatment for at least 7 days. But on top of that, if in angular cheilitis patient, if there is any inflammatory dermatitis, then you can also prescribe them hydrocortisone 1% cream. They need to apply it topically to the angles of the mouth 2 times daily until inflammation subsides. Combination products are also available, but it is important because their dose and duration is a bit different, so it is generally recommended to prescribe them separately. If oral candidiasis is present, treat with antifungal therapy and seek specialist advice for persistent angular cheilitis. Treatment for mixed infection may be required, or it may be a symptom of a systemic condition such as Crohn's disease or granulomatous disease. Okay, so for if even after doing this treatment, their symptoms are not going away, then you need to refer them to the specialist. So you just need to do very little things in any case. Even if you are not sure and if your patient is not responding to your treatment, then you just need to refer him. Okay. All right, so our candidiasis topic is completed here. And for the nystatin, it is very important that you educate your patient that it does contain a lot of sucrose, so that may lead to decays. So you just need to inform them. Okay, and tomorrow or next time, we will start with the oral mucositis topic. All right, thank you so much, guys, for watching my videos, and do like, share, and subscribe. Thank you.